journey.
Welcome to the second day of the first virtual Lupus Mini Health Conference presented by the Lupus Foundation of Northern California. For those of you who attended yesterday, some of the introductions will sound familiar. We are repeating them for anyone attending today for the first time. My name is Corrine Belazna, and I am excited to be your host today. I began volunteering with the LFNC in 2012. Over the past 10 years, I have created their online medical article library consisting of over 200 document resources, assisted in preparation of annual financial audits and tax returns, and provided a variety of other financial and business advisory services. I am an instructor for new patient education classes and have helped plan and facilitate events such as the Outrun Lupus 5K, the Purple Ribbon Awards Gala, and the LFNC hosted medical and health conferences. We are happy you could join us today. LFNC also has 2 more upcoming Lupus Mini Health Conferences planned for 2021, one on August 27th and 28th, and a Spanish language conference on October 15th and 16th. Don't miss your chance to help LFNC outrun lupus on September 25th. This 5K will be a hybrid event, so join us at Campbell Park in person or wherever you feel comfortable. For additional information or resources, please visit our website, www.lfnc.org, or email us at communications@lfnc.org. We hope you were able to join us yesterday for Dr. Bush's presentation on current research updates and treatment for lupus, as well as a makeup demonstration from Jane Chaichian. If you missed them, the recordings can be found on our website, www.lfnc.org. So now I will go over the agenda quickly and then we'll get started. The first hour, Dr. Chaichian will discuss pregnancy in SLE, and afterwards we'll be answering questions. You can ask a question by clicking on the Q&A button in the toolbar of your Zoom window and typing your question, either during the presentation or during the Q&A session. You can ask questions anonymously by clicking the checkbox next to your question before clicking submit, so don't be shy. We will then have a break and return at 2 o'clock and listen to our panel of lupus patients discuss their lupus journey as it relates to pregnancy and starting a family in general. Remember, you can attend any of the sessions with the same link, so if this sounds interesting, you can still join us. Before you leave a session, be sure to complete the quick survey. Now, let me introduce Dr. Chaichian. He is a clinical assistant professor in the Division of Immunology and Rheumatology at Stanford University and serves as the director of the Stanford Lupus Clinic and the Stanford site director for the Lupus Clinical Investigators Network. In addition to clinical trials, his other research collaborations include work that examines the representation of gender and race ethnicity in randomized clinical trials in SLE, as well as pregnancy-related outcomes in lupus. Among the committees in which he serves is the Arthritis Foundation of Northern California's Medical and Scientific Committee. Welcome, Dr. Chaichian.
Hi, everyone. Thanks for inviting me to speak with you today. I'm honored to be here. Today, I'm going to be talking to you about the topic of lupus and pregnancy, which is a very important topic. And hopefully today I'll be able to provide some additional background regarding the important counseling that needs to occur when you're thinking about pregnancy in the setting of lupus, the specific risks associated with pregnancy and lupus, information about medications that are safe and those that aren't safe to make an informed decision about how to manage your lupus going into pregnancy and during pregnancy, And overall, sort of the take-home message will be that although lupus is inherently a higher risk scenario for pregnancy, with few exceptions, most women with lupus ultimately can have a successful pregnancy, and it's all about managing the risk and being aware of those and working closely with your providers. So I'm going to be sharing my slides here. These are my disclosures. So in terms of preconception counseling, this should be discussed early on with any woman who has lupus of reproductive age, and really should be an ongoing discussion over time and be addressed as circumstances may change, and the discussion should be reflecting that. It's also important to discuss whenever you're considering starting a medication that could pose risks in the setting of pregnancy. And among the many topics that should be part of the discussion in relation to both maternal and the fetal health include the impact of your disease activity, your specific autoantibodies related to lupus, and specific organ systems involved, such as kidney involvement. And this should really be a shared decision-making approach between you and your providers, not just your rheumatologist, but your obstetrician, maternal fetal medicine, and other relevant providers in an open and collaborative discussion. So the first topic of preconception counseling we'll talk about is contraception. This is an essential component of preconception counseling. It provides you as a patient with information on what's safe in terms of birth control options, ensures that birth control is available to you if you're taking medications that aren't safe for pregnancy. And it really helps ensure that once you are ready for pregnancy, you're on a medication regimen that's hopefully safe for pregnancy, and you're in a low disease activity state, which we'll talk about as one of the most important factors going into a pregnancy to ensure better outcomes. Which specific contraceptive you use really depends on your preferences, but also specific disease-related factors, including your lupus activity, and as well as the presence of specific clotting proteins known as antiphospholipid antibodies, or if you have antiphospholipid antibody syndrome, which we'll define later, but is the presence of these antibodies really in the setting of clinical events associated with them. So it's been actually looked into, and contraception counseling, even though it's so important, especially in the setting of lupus, is often not addressed as well as it could be. A study out of UCSF from 2008 showed that 86 out of 206 women that were evaluated in this who had lupus were at risk for unplanned pregnancy. Almost 60% had received no contraception counseling within the previous year, and they were no more likely to receive counseling if they were on lupus medications associated with birth defects. About half were using only barrier methods, which we know are not sufficiently safe and protective against pregnancy. And only 13% were using the much more effective method of IUDs or intrauterine devices. So overall, the lupus community can do better in terms of contraception counseling. I'm going to be highlighting the American College of Rheumatology 2020 guidelines that go over reproductive health, and we'll focus on these throughout the talk. Where relevant, specifically on the issue of contraception and lupus for patients with stable low disease activity. There are a number of options that they strongly recommend, including IUD, progestin implant, combination estrogen progesterone pills, progestin-only pills, a vaginal ring, and unless you're at increased risk for osteoporosis, the DMPA, they conditionally recommend the highly effective IUDs or subdermal progestin implant because of all these methods, they have the lowest failure rates. There are going to be other patients with lupus who don't unfortunately have low disease activity. For those who have more moderate or severe disease activity, which again is a decision and a designation that should be based on the assessment of your providers, including your rheumatologist. In this setting, it's strongly recommended to use either the IUD method or progestin-only contraceptives over a combined estrogen-progestin contraceptive, including in patients who have nephritis or active lupus kidney involvement. And part of this is because estrogen-containing contraceptives have not been studied in patients with more significant disease activity. Whether you have significant disease activity or milder disease activity, there's a conditional recommendation against use of the transdermal estrogen progestin patch, mainly because it's not been directly studied in patients with lupus, but also there's a concern regarding an increased risk of flare or clotting due to the increased estrogen exposure compared to oral or transvaginal methods. And one point specifically, patients with lupus not uncommonly may be placed on mycophenolate mofetil or a related medication called mycophenolic acid. And it's thought that these can reduce estrogen and progesterone levels and may impede contraceptive efforts. So in this setting, their recommendation is to use an IUD or 2 other methods of contraception together. In the setting of having antiphospholipid antibody positivity with lupus, it's a strong recommendation to use one of the IUDs or the progestin-only pill. They recommend strongly against using a combined estrogen-progestin pill for the main reason that estrogen increases the risk of clotting, and these patients are already at a heightened risk of clotting and its related consequences. They don't recommend DMPA due to concern regarding clotting as well. And at this current juncture, there's a relatively lack of data on progestin implants, so it's not recommended in this setting, or there's no comment towards whether or not to use it, just due to insufficient data. Certainly, emergency contraception is an important topic to be discussed with all patients, and because the risks of emergency contraception are low compared to the risks of an unplanned pregnancy, particularly if your disease activity is elevated or you're on a medication that isn't safe in the setting of pregnancy. So it's strongly recommended to have this discussion in all lupus patients. And the levonorgestrel is recommended in this setting if needed. It's over the counter, it's readily available, and it's safe to use in lupus patients, even those who have positive antiphospholipid antibodies. This is just a table from the guideline that summarizes the various methods, and I just highlighted in red some of the recommendations against. So the DMPA injections to be avoided in women with positive antiphospholipid antibodies. The combined pill avoided in women with moderate or severe lupus activity, as well as positive antiphospholipid antibodies. The transdermal patch to be avoided in lupus, as well as those with positive antiphospholipid antibodies for several reasons, including a lack of direct data in this setting, and the vaginal ring to be avoided in women who have very active lupus or positive antiphospholipid antibodies. Fertility and assisted reproduction techniques are important topics as well that I wanted to highlight. In terms of the topic of family planning specifically, there's a study that showed that among women with lupus who were interested in having children, nearly 2 out of 3 had less children than they originally planned. And it's been thought that there are multiple reasons that women with lupus may have less children than they originally planned. One is there's a higher rate of fetal loss in lupus pregnancies, both from lupus, but also in some cases when antiphospholipid antibodies are present. Premature ovarian failure is a concern, particularly if you've been exposed to certain medications that fall within the class of alkylating agents, the key one being cyclophosphamide, which is often used for very severe manifestations of lupus, such as severe lupus kidney involvement. And women with lupus often conceive later than women in the general population for a variety of reasons. Some of it's related to making sure their disease is under control versus other factors. But with this, then there's an age-related normal decline of fertility. And then lastly, just fear. There's misconceptions regarding the risk of pregnancy in lupus in some cases. In other cases, just a fear in general about the topic of pregnancy. And so hopefully this talk will help alleviate some of those concerns and provide further context regarding the risks in pregnancy and lupus and ways to mitigate those risks. There's a couple studies that have suggested that there may be decreased fertility in the setting of lupus. One study found that anti-Müllerian hormone levels, which is a biomarker of ovarian reserve, were significantly reduced in 15% of premenopausal women with lupus, notably who had not received cyclophosphamide, compared to only 3% of controls. And another study is showing other autoantibodies that may impact fertility as well. And so this may be part of the reason why women with lupus have issues with fertility, but again, we've highlighted some other ones, including medication-related factors as well. So in women who have difficulty with conceiving and are interested in assisted reproduction techniques, this is certainly something that's being increasingly considered. There are a variety of options that can be pursued, including ovarian stimulation, in vitro fertilization or IVF, as well as embryo transfer. And this certainly, as with all of these topics, requires sort of coordination and discussion between you and your providers, including your rheumatologist, a reproductive endocrinologist, and your infertility fertility specialist. On this topic, the guidelines strongly recommend proceeding with assisted reproduction techniques in women with lupus who have stable, low disease activity or quiet disease, who are negative for antiphospholipid antibodies, and advise having at least 6-month window of inactive or low disease activity going in. They conditionally recommend against increasing prednisone during assisted reproduction techniques. And if you have a flare, treat accordingly, but mainly monitoring, not proactively adding a medication like prednisone, just because prednisone can potentially have risks depending on the dose used and the duration. In women with lupus who are antiphospholipid antibody positive, if it's just the antibodies are positive and they haven't had clinical manifestations associated with them, there's a conditional recommendation for prophylactic anticoagulation with heparin or low molecular weight heparin. There's a strong recommendation for the same treatment in women who have obstetric antiphospholipid antibody syndrome, which is having these antibodies at a certain criteria and an obstetric complication, which we'll talk about a little bit later, how that's defined. And then it's strongly recommended to use actually therapeutic levels of anticoagulation in women who have had a clotting event that meets criteria, such as an arterial or venous clot, in addition to having these antibodies. On the topic of embryo and oocyte cryopreservation, this is typically considered in women who are stable enough to pursue ovarian stimulation, but are either unable or not yet ready to proceed with pregnancy. And the guidelines currently strongly recommend continuing background lupus medications that are necessary, with the exception of cyclophosphamide, which directly impacts maturing follicles in patients who have stable disease activity. We do certainly need more data on specific medications in this setting, although there is the data on cyclophosphamide, which has prompted the recommendation against having that in this setting. On the topic of fertility preservation, if you are taking cyclophosphamide, certainly the risk of ovarian insufficiency is related to various factors, including the patient's age, as well as cumulative dose. So the greater the dose over time, that sort of is directly relevant to your risk of having issues with fertility on this medication. Leuprolide is the most common sort of monthly gonadotropin releasing hormone agonist co-therapy. So that's the treatments that's done to preserve fertility in patients with cyclophosphamide. And it's conditionally recommended when receiving monthly IV cyclophosphamide. And it's reasonable to consider if you're on oral cyclophosphamide. Oral cyclophosphamide, fortunately, is not really used that often anymore. It can be very effective, but it has a very high risk of side effects and risks, at least more so than IV cyclophosphamide. Nevertheless, given that the risk of ovarian insufficiency is typically higher with oral cyclophosphamide due to increased dosing, even though there's an absence of data of using something like leuprolide in that setting based on the literature, the guidelines felt it was very reasonable to consider in this setting. Nowadays, actually, more and more when cyclophosphamide is considered for lupus, and you may have experienced this in your own, in the management of your lupus, sometimes cyclophosphamide is given in a lower dose called Euro-Lupus protocol, and that in that setting, it's actually been, there's some data that fertility is actually preserved, and you may not need to use something like leuprolide. So I'm going to focus the next section of the talk on pregnancy risks in lupus and sort of detailing those a little bit further. So as with anything with lupus, there's a lot of heterogeneity in terms of factors that go into the risks. So there's maternal factors, including age, race, ethnicity, disease-specific factors, including disease activity, lupus markers. And so not all lupus patients are different. And even within a lupus patient, sometimes these risks and disease-specific factors evolve over time. All these things go into the risk of adverse outcomes, which we're trying to avoid in pregnancy, including preterm birth, preeclampsia, and fetal loss. So this table, table 1 here, is actually from a study using the nationwide inpatient sample from 2000 to 2003, and it highlights some of the demographic differences between lupus pregnancies and non-lupus pregnancies. This was data that was collected on women admitted to all types of hospitals, so there was a wide range of lupus severity. But in general, the mean age and the age of delivery over at least 35 were a greater proportion among the lupus pregnancies. There were some other differences noted as well in terms of between lupus and non-lupus pregnancies that can be shown here. The main difference, though, again, highlighting here is that lupus pregnancies tend to occur a little bit on average at a later age of onset. There are also differences in comorbid illnesses in women with lupus, and these are a range of comorbid illnesses highlighted here, including higher risk of association with pregestational diabetes in women with lupus who deliver, hypertension, pulmonary hypertension, which is elevated pressure in the right side of the heart, renal failure, and clotting issues. In terms of medical complications in lupus pregnancies compared to non-lupus pregnancies, they also found increased risk of clotting complications, infectious complications such as pneumonias, and issues with the blood counts, such as need for transfusions, postpartum hemorrhage, anemia at the time of delivery. On the right is an interesting study, and it sort of just highlights that this is not exclusive to US lupus pregnancies, but in other cohorts outside the US, including the SLINK lupus cohort, which is out of a Swedish nationwide registry. They found that similar to the nationwide inpatient sample in the US, higher rates of C-section, preeclampsia, and preterm birth among women with lupus in that Swedish registry. So the Swedish registry data is in the dark purple. The nationwide inpatient sample is sort of highlighted in the sort of lighter purple color. And both for all three of these complications, the risk is higher compared to the non-lupus patients, which are in both the dark green and lighter green bars. Another interesting study was the PROMISE study. Data was published in 2015. This was a multi-center prospective study of nearly 400 patients with lupus. About half were non-Hispanic white, about just under a third had a history of prior lupus kidney involvement. They did exclude women with high disease activity, so that is one sort of factor to weigh in when you're interpreting the results, and women who had active lupus kidney involvement at the time, or were on at least prednisone doses of 20 milligrams or higher than 20 milligrams at the time of enrollment. But basically, in their overall cohort of lupus patients, they found that the risk of any adverse outcome was about 19% among lupus pregnancies, fetal or neonatal death 4%, preterm birth 9%, and small for gestational age about 10%. And it's important, this highlights sort of the risk factors associated with lupus that influence the risk. So there was a separate subset of patients that we looked at who didn't have some specific risk factors. So patients who did not have platelet counts less than or equal to 100,000, or did not have a certain clotting protein called lupus anticoagulant, or were not on an antihypertensive medication, for example. And this sort of lower risk lupus group fared better for all of these outcomes. But you can see even that group, which is in the lights gray in the middle, had increased risk of all these adverse outcomes, and compared to the white bar on the right, which is the subset of patients who did not have lupus. Some interesting additional results from the study. Some of it's sort of, as you would expect, the predictors of bad pregnancy outcomes included the mother having a flare, higher disease activity, a smaller rise in the C3 complement level later in pregnancy. So these normally rise as just a part of pregnancy, and if they don't rise or they drop, that's a concerning factor. Presence of lupus anticoagulant, antihypertensive use, or low platelets. And then the highest risk patients in their study were actually those who were the lupus anticoagulant positive. We'll highlight throughout this talk the importance of checking antiphospholipid antibodies as a form of stratifying your risk in pregnancy. And among women who were lupus anticoagulant negative, if they were non-white or Hispanic and taking antihypertensive, they were also higher or highest risk. One sort of point to counterbalance this is that it's reassuring that in their cohort, they did not see severe lupus flares as a common outcome. So most of the flares tend to be mild or moderate, which is encouraging. This is data from a meta-analysis, which is sort of when you combine multiple studies together and sort of pull the data and analyze it that way. This was over about a 15-year period, and it compared both maternal and fetal outcomes in pregnant women with lupus, over 3,000 lupus women with lupus who were pregnant versus non-lupus pregnancies. And for various outcomes listed here, preeclampsia, prematurity, small for gestational age, and the others listed, the risks were higher in lupus. In data not shown here, there's also an increased risk of spontaneous abortion, clotting, hypertension, and C-section, just highlighting the fact that we discussed that lupus is inherently a higher risk scenario. Preeclampsia and preterm birth are important outcomes to be aware of and to monitor for, and to work closely with OB to try to reduce the risk of these. There's certainly data in lupus about how these present and what the risk factors are. In lupus, preeclampsia tends to be medically indicated rather than spontaneous. Aspirin can help reduce the risk, and it works best if given before 16 weeks of gestation. And there are a variety of factors in lupus patients that may increase the risk, including history or active lupus kidney involvement, antiphospholipid antibodies, low platelets, or a drop in the complement levels. Preterm birth tends to be more commonly medically indicated, as in due to lupus activity. In a study that we actually did with some collaborators at Stanford, as well as outside of Stanford, we found that a considerable proportion of the risk of preterm birth in lupus pregnancies can be mediated through preeclampsia itself. The factors associated with the higher risk overall are listed here and include some overlap with the preeclampsia risk, but some different ones as well. So just important to know these and to have discussions about these with your rheumatologist and OB provider early on, preferably well before pregnancy, so you're informed about the risks. Once hyperpreeclampsia is early onset, which is defined as less than 34 weeks of gestation when it appears. And the take home from this study out of Sweden is that the risk is highest among first pregnancies among women with lupus, but it still persists compared to the general population in terms of the increased risk, both overall and in subsequent pregnancies. They also found that some of the risk is mediated not through the traditional risk factors such as smoking or pregestational hypertension, but independent of that as well. But further study needs to be done on this topic. One thing that is very important to sort of differentiate is preeclampsia from lupus nephritis. Lupus nephritis being the other sort of term for lupus kidney involvement or inflammation of the kidneys. It's very hard often to differentiate the two, and you can have preeclampsia and also concurrently have active lupus kidney involvement. The challenge is that they both can potentially cause increased protein in the urine, worsening kidney function, hypertension, and low platelets. There are some ways in some cases to differentiate the two or to help do that. Active lupus kidney involvement tends to be more commonly associated with a drop in the complements during pregnancy and a rise in the double-stranded DNA antibodies. And if the concerning features are developing before 20 weeks gestation, by definition, this excludes preeclampsia and points more towards lupus kidney involvement. But if it's later in the pregnancy, it's often difficult to differentiate. And the importance of working with your providers to come up with a satisfactory answer in terms of what's more likely is critically important in terms of treatment, because preeclampsia and lupus nephritis are treated in very different ways. The optimal outcome for preeclampsia is actually delivery of the baby, whereas if it's lupus nephritis, better outcomes are with actually increasing your background regimen for your lupus, reducing the degree of inflammation going on to treat the kidney inflammation. Here I wanted to just highlight that African American and Hispanic women with lupus bear a disproportionate burden of the adverse pregnancy outcomes. And so this is something that's been shown in various studies, including the PROMISE cohort, the nationwide inpatient sample data from 2008 to 2010. And this is not unique to lupus pregnancy. Outside of pregnancy among lupus patients, it's been seen in multiple studies that there's a different sort of risk of complications based on race and ethnicity. I want to spend a couple slides here on neonatal lupus, which is an important topic. This is a form of passive autoimmunity that's due to transfer of specific antibodies through the placenta that the mother carries. And fortunately, these tend to disappear by about 6 to 8 months of life, but before then they can affect the baby and have adverse consequences. The specific antibodies that are relevant here are the ANTIRO, also known as SSA, and the anti-LA or SSB antibodies. Most commonly, the manifestations of neonatal lupus will be a rash, about 10% risk. temporary abnormalities in liver tests can occur, or blood count abnormalities. But the most worrisome complication, and why it's so critical to identify this and try to prevent this, is that a small subset of patients of fetuses who develop neonatal lupus will have heart involvement, and the most worrisome outcome of that is complete heart block. So complete heart block develops in about 2% of exposed pregnancies of women with these antibodies who have not had a prior infant with neonatal lupus. If you have had a prior infant who has had either skin or cardiac features of neonatal lupus, the risk of this complication of complete heart block in a subsequent pregnancy goes up to about 13 to 18%. And we think that the level of these antibodies correlates with the risk. So the higher levels tend to correlate with higher risk. This typically presents around week 16 to 26 of gestation. It's often, there's a sign of milder degrees of heart block that can occur. And if it's at that setting, it's potentially reversible. Once it becomes complete heart block, unfortunately, it's not. And the consequences are that, there are fetal mortality rates associated up to 20% in utero or within the first year of life. Over half of babies who do survive require a pacemaker. Fortunately, several studies have shown that hydroxychloroquine can reduce the risk of cardiac neonatal lupus. So that is an important point to consider when counseling patients going into pregnancy, among the other benefits of hydroxychloroquine in this setting. And so the ACR, American College of Rheumatology 2020 guidelines on this topic, if you have these antibodies, the fetal Doppler echo remains the preferred screening tool to look for heart block. And so if you've had a history of an infant with complete heart block or neonatal lupus, there's a conditional recommendation to do weekly fetal echoes between week 16 and 18 through week 26. And if you haven't had a history of an infant with complete heart block or neonatal lupus, the recommendation is still to screen between weeks 16 and 18 through week 26, although the specific interval has not been conclusively defined. Those should be less than weekly. And hydroxychloroquine is recommended in this setting. There's retrospective data that shows that in pregnant women who've had a prior child with cardiac neonatal lupus, like we talked about, it can reduce the risk in a subsequent pregnancy. And so the recommendations state to conditionally recommend treating all women positive for these antibodies with Plaquenil during hydroxychloroquine during pregnancy. And if you have the baby has a milder form of heart block, there's a conditional recommendation to use oral dexamethasone at a dose of 4 milligrams per day. But because this is a fluorinated steroid, and fluorinated just is to be differentiated from non-fluorinated steroids. An example of a non-fluorinated steroid would be prednisone. But these fluorinated steroids cross the placenta easily. And so the goal is to treat in this setting, but to limit treatment for a few weeks to avoid some of the side effects that the steroid could cause. Conditionally, not side effects, but adverse outcomes, including intrauterine growth restriction and preterm birth. And again, highlighting that once heart block occurs, it's irreversible. So steroids at that point are unlikely to be effective. I'm going to spend a little bit of time talking about lupus disease activity during pregnancy. Before we do that, just to highlight that physiologic changes during pregnancy can sometimes look somewhat similar to lupus activity, but there can be subtle differences. So facial flushing, redness along the palms often accompany pregnancy, to be differentiated from some of the more specific rashes of lupus, such as discoid lupus or like a butterfly photosensitive rash on the cheeks. Joint pain is common during pregnancy, but lupus arthritis tends to be more inflammatory with swelling or stiffness that's typically prolonged. You can get fatigue in both settings, you can get swelling in both, but you worry more about things like lupus nephritis with swelling. You can get mild shortness of breath as a physiologic part of pregnancy at rest, but also with lupus, you can get complications related to inflammation around the lining of the lungs called pleurisy or pleuritis. And then various lab abnormalities can be seen in pregnancy, but then there are sometimes some differences in lupus activity that should be monitored for. One of the differentiating factors is physiologically in pregnancy, we talked about complement levels tend to rise. Lupus activity would typically be suggested by a decrease in the complements, or at least the complements failing to rise. And lastly, you can get some degree of proteinuria as part of normal pregnancy, but higher degrees you worry about lupus kidney involvement or preeclampsia. And so these are the things that your rheumatologist and obstetrician are often looking for in monitoring. A number of studies have looked at disease activity in pregnancy. And in general, the consensus is that there's a higher risk of lupus activity during pregnancy, but the rate of flare is very variable, from 25 to 65%. And that's just due to different studies having different study design, different study populations specifically looked at. But a number of factors have been shown to predict flares. Probably one of the key ones to highlight here is lupus disease activity at the time of or within 6 months prior to conception. We talked about this, that really making sure your lupus is as well controlled as possible in that 6-month period before pregnancy is one of the key determinants of how successful the pregnancy will be. We talked about the complements. Both active and prior lupus kidney involvement have been shown to predict flares, the presence of antiphospholipid antibodies, stopping hydroxychloroquine, so the importance of being adherent with the medication, certain prednisone higher doses, and young maternal age. Importantly, most flares during pregnancy tend to be mild to moderate. And some of the more commonly affected organs that have been shown in some studies are listed here. It's a wide range of organ systems that can be involved. But again, most flares tend to be mild to moderate. This is an interesting study out of Brigham Women's Center out of Harvard, where they looked at organ-specific lupus activity, which occurred in about 54 out of 147 lupus pregnancies. And they found that hematologic involvement, so low blood counts, were the most common, but followed by kidney involvement as well. And on the right from the same study, this basically highlights the importance of looking at what's going on the 6 months before pregnancy, because they actually found that in some cases, in a majority of patients, and in others, in a substantial minority of patients, the specific organs that were involved in the 6 months before pregnancy tended to be the ones that were active during pregnancy. So kind of gives you a sense of what to look for during pregnancy. And again, sort of reiterates the point that making sure your lupus is as well controlled as possible, and working with your providers to ensure that going into pregnancy in that 6 months, less likely to flare during pregnancy. I want to go in a little bit more depth on a couple slides here about lupus kidney disease in pregnancy. Lupus nephritis impacts up to 30% of lupus pregnancies, so it's not rare. A history of lupus involvement, or kidney involvement, or active lupus involvement at the time of conception has been associated with a higher risk of kidney flares during or after pregnancy, as well as a higher risk of preterm delivery. And active kidney involvement at the time of pregnancy is associated with a higher risk of any adverse maternal outcome. It's still being sort of debated whether a prior history of kidney involvement leads to worse fetal outcomes. And from the 2012 American College of Rheumatology guidelines on lupus nephritis and their comment on lupus kidney disease management during pregnancy, for treatment, if you've had lupus kidney involvement specifically and it's not active, they don't recommend any additional specific treatment. Certainly, if you're already on hydroxychloroquine, that's the standard recommendation to continue it. If you have mild activity and a history of lupus kidney involvement, hydroxychloroquine is sort of further recommended. If you have clinically active lupus kidney involvement, typically what's used is steroids, just because they work the quickest and can sort of halt disease activity fastest, but using the lowest dose necessary for the shortest amount of time is always the rule. You can add azathioprine if needed. Azathioprine has overall favorable safety profile in the setting of pregnancy. And in the typically uncommon scenario where you would have persistently active severe kidney involvement during pregnancy, although these certainly do occur, considering delivery at some point after 28 weeks, hopefully the later the better, because prematurity is associated with a number of risks, to ensure the best outcomes. We've talked throughout a little bit about the antiphospholipid antibodies and their role and how they influence risk of pregnancy and lupus, but we'll talk a little bit more here. These antibodies are associated with increased risk of clotting, venous, arterial, small vessel clotting, and both obstetric complications, including miscarriages, as well as other outcomes. And these are fairly common in patients with lupus. Not all patients who have these will have a complication, but they certainly increase the risk. And when we talk about antiphospholipid antibody syndrome, that's separate from just having these antibodies. That's when you have these antibodies that persist at a specific threshold, and you also have had a clotting history or specific obstetric complications, then you're classified as antiphospholipid antibody syndrome. And you can have lupus and have this at the same time. Thrombotic antiphospholipid antibody syndrome refers to patients who met the lab criteria and have had clotting event associated with it. And obstetric antiphospholipid antibody syndrome is patients who've had the lab criteria and prior pregnancy complications consistent with this syndrome who do not have another cause. So it's one way is greater than or equal to 3 consecutive early pregnancy losses, less than 10 weeks gestation, or any late pregnancy complication that's associated with placental insufficiency. And we think that the specific antiphospholipid antibody profile matters. So there are specific high risk profiles, which I've highlighted here, including like multiple of these antiphospholipid antibodies being positive, or particularly the presence of a lupus anticoagulant. And if you have a high risk profile, it's associated with a number of adverse outcomes listed here, including preterm birth, preeclampsia, fetal loss. Interestingly, when they've studied if monitoring the levels of the antiphospholipid antibodies throughout the pregnancy, the change in the levels don't seem to associate with the outcomes. It's more sort of the presence at one point of a high risk profile is the key. And the 2020 ACR guidelines going over antiphospholipid antibodies and syndrome in pregnancy for patients who just have the antibodies present but don't have antiphospholipid antibody syndrome. There's a conditional recommendation to treat with low-dose aspirin during pregnancy to prevent preeclampsia and to start before week 16 and continue through delivery. They conditionally recommend against also adding prophylactic dose heparin, but this needs to be individualized. They acknowledge that there may be certain scenarios where a patient just has the antibodies, but it's an especially high risk profile. And so that should be a discussion between your obstetrician and rheumatologist and other relevant providers. In women who have obstetric APS plus positive antiphospholipid antibodies, there's a strong recommendation to combine not only low-dose aspirin, but also with prophylactic dosing of heparin, and to continue this for 6 to 12 weeks after delivery. In women who have thrombotic APS, who have had a clotting event, like a DVT or a PE, and have a positive antiphospholipid antibodies, there's a strong recommendation to treat low-dose aspirin in combination with therapeutic dose, so higher dosing of heparin during pregnancy and again postpartum. So there are a select few scenarios where it may be prudent to consider delaying or even in some cases avoiding pregnancy in lupus. These are if you have a severe disease flare within the prior 6 months, stroke within the prior 6 months, severe pulmonary hypertension, severe inflammatory lung changes called restrictive lung disease, severe kidney impairment, advanced heart failure, history of severe preeclampsia or pregnancy syndrome called HELP. So these are very limited scenarios where it may make sense to readdress whether pregnancy makes sense at that time. Obviously, this is a very intensely personal decision, and there may be scenarios where you may fall into one of these categories and still strongly desire to have a pregnancy. So we realize as providers, it's a very individual decision. And so in that case, it's always important and just highlights to have an open, honest discussion with all of your providers, and everybody can kind of weigh the risks and benefits of pregnancy and come up with an approach that's a mutual decision. Despite that last slide, I wanted to sort of reinforce the take-home message that I was sort of discussed at the very beginning, is that all of these are to say that there are higher risks of pregnancy in lupus. It's inherently a high-risk situation, but to sort of add several points of optimism as well, the magnitude of the risk has substantially decreased over the years. There's lower rates of pregnancy loss substantially compared to over 50 years ago or even 60 years ago compared to some data that was published in the early 2000s. There's fewer preterm births over time, and rates of in-hospital maternal mortality compared to the general population have significantly decreased, even looking at from a time frame of 1998 to 2000 to looking at 2013 to 2015. So outcomes have improved. And like I mentioned, in most cases, women with lupus will ultimately be able to have a successful pregnancy. I want to spend a few slides here just going over a little bit more of general screening, monitoring, and treatment measures in lupus. So it's strongly recommended, based on the most recent guidelines, to test for lupus anticoagulant, anticardiolipin, and the beta-2 glycoprotein antibodies, the so-called antiphospholipid antibody tests, once before or early in pregnancy, and not to repeat these during pregnancy. Like we talked about, the change in titer doesn't seem to be necessarily as predictive as the specific risk profile initially. They strongly recommend testing for the anti-Ro and LA antibodies once before or early in pregnancy. And again, don't recommend repeating the test during pregnancy. And the strong recommendation is, as good practice, to monitor your lupus activity with a history and exam and lab tests at least once per trimester. Certainly this needs to be individualized, and patients who have more significant disease activity, the visits should be more frequent, and the monitoring should also be done at shorter intervals. Hydroxychloroquine is recommended that for all women with lupus during pregnancy if possible, based on the 2020 guidelines, and it's strongly recommended to continue if they're already taking it, and conditionally recommended to start it if they're not already taking it before conception, as long as there's no contraindication. And in terms of aspirin, there's a conditional recommendation to treat lupus patients with low-dose aspirin beginning in the first trimester. Again, we talked about the benefits of aspirin, including preeclampsia risk reduction. So medication use in lupus pregnancy is sort of critically important because you want to control the lupus, make sure disease activity is minimized, both going into pregnancy and during pregnancy to optimize outcomes. On the other side of it, obviously, you want to make sure these medications are fully compatible with pregnancy because of you don't want to be treating the lupus and causing adverse fetal outcomes. In treatment of lupus flare during pregnancy must take into account this importance that the medication needs to be safe in pregnancy, but otherwise the same principles apply. You want to treat based on the organ involvement and the severity of the flare. So a more severe flare would require more treatment than a milder flare. And like I already just mentioned, undertreated lupus during pregnancy also has its own adverse outcomes, both to the baby and the fetus. It needs to be counterbalanced with making sure that the medications used are safe. Unfortunately, this has been an area of study, and groups such as the American College of Rheumatology have weighed in. From the most recent guidelines from 2020, the overall recommendations are as listed here. In terms of strongly recommended medications, hydroxychloroquine, azathioprine are both listed. They recommend strongly to discontinue cyclophosphamide, thalidomide, methotrexate, and mycophenolate within 3 months prior to conception, acknowledging that these have been associated with adverse pregnancy outcomes. Discontinuing leflunomide a full 2 years prior to conception, or checking metabolite levels and treating with a washout if needed. That's just because leflunomide specifically stays in the body for a really long time, so at low levels, and so even those low levels at a certain threshold can cause problems. So it's important to follow these recommendations. And tapering higher doses of non-fluorinated steroids to less than 20 milligrams daily prednisone, and whenever possible, if needed for controlling your lupus disease activity during pregnancy, your provider should be working with you to transition it to a safe non-steroid medication. There's a conditional recommendation to use NSAIDs as needed during the first and second trimester. So medications like ibuprofen and non-selective NSAIDs are favored over the COX-2 specific ones. Conditional recommendations to continue cyclosporin and tacrolimus, and you can continue in trying to conceive, though you should stop once pregnancy is confirmed when it comes to rituximab or belimumab. Low-dose steroids can be continued if clinically indicated, again, though trying to minimize the amount of steroids whenever possible. Cyclophosphamide can be used if needed for life-threatening disease in the second or third trimester as a conditional recommendation, but should really be avoided in the first trimester. And rituximab can be used as a conditional recommendation throughout pregnancy if needed for organ or life-threatening disease. Notably, they conditionally recommend stress dose steroids at the time of cesarean delivery, but conditionally recommend against it in the setting of vaginal delivery. And because NSAIDs in the third trimester can be associated with premature closure of a structure called the ductus arteriosus, it's recommended to not use NSAIDs in that setting. Medications and breastfeeding are also an important topic because sometimes lupus activity can increase after pregnancy, and so in that postpartum period, if you're nursing, you want to be sure that the medication you're using doesn't accumulate excessively in the breast milk and causing any risks to the baby. So the 2020 guidelines regarding medication use in this setting strongly recommend hydroxychloroquine, sulfasalazine, and rituximab being acceptable medications. If you're on prednisone at least 20 milligrams daily, they recommend delaying breastfeeding or discarding the breast milk accumulated in the 4 hours following your steroid dosing. Recommendation is for prednisone if it's less than 20 milligrams daily, conditional recommendation for NSAIDs, azathioprine, calcineurin inhibitors, which includes tacrolimus and cyclosporin, as well as belimumab. And then recommendations against methotrexate, conditionally and strongly against cyclophosphamide, thalidomide, leflunomide, and mycophenolate mofetil. So this is sort of a roadmap or a guide. It's, I think, important for you as a patient to be aware of the more recent recommendations, what's acceptable to use during pregnancy, as well as during breastfeeding, to make an informed decision with your provider on medications, and to know these things in advance, because again, the importance of planning and thinking about these things well before conception to ensure laying the groundwork for successful pregnancy. So lastly, I wanted to just end with just sort of a summary slide, going over some of the key concepts we talked about, or sort of how to counsel patients with lupus regarding pregnancy, and sort of the general framework we approach. Again, there are select scenarios that are especially high risk. So again, lupus is high risk, but those uncommon scenarios such as severe pulmonary hypertension or severe disease activity, in those scenarios, advising against pregnancy or delaying it, and having a discussion with your providers in a sort of an open and collaborative approach. That being said, like we've talked about, in most situations, if disease activity is well controlled, women with lupus can have a successful pregnancy. The risks are higher still, but outcomes can be favorable overall. And in those settings, the importance is evaluating disease activity. We talked about, if you have active disease, again, holding off temporarily and discussing contraception. But if disease is well controlled, proceeding with planning for pregnancy, if again, that 6-month window of low or inactive lupus activity has been met. And then the importance we talked about throughout is risk stratifying. So your providers will talk to you about what your risk is based on not only your disease activity, but what antibodies you have, if it's the antiphospholipids or the anti-Ro, the anti-Law antibodies. And then individualizing your plan among all your doctors based on your risk profile. So it's not sort of the same plan for everybody. It needs to be individualized according to your preferences, the specifics of your lupus, because everybody's lupus can be very different, and coming up with a plan that makes the most sense for you and taking into account your disease activity. And then you want to optimize medications and counsel patients on the need to continue safe medications. And we hopefully have gone over the importance of the safe medications that can be used during pregnancy as well as during breastfeeding. So I look forward to answering additional questions during the live Q&A section coming up. And again, thank you for inviting me to speak with you today. It was a pleasure.
Now we will open to our Q&A portion of the event. We will begin with questions that are asked during the presentation, and feel free to ask additional questions while we're talking. Remember, it's the Q&A button in the taskbar of your Zoom window. We'll try to get through as many questions as we can live, and we'll email you answers to any questions that we are not able to get to today. Thank you, Dr. Chaichian. Let's start with, what suggestions do you have in coordinating care between my rheumatologist and OBGYN when trying to get pregnant?
I think, obviously the most important thing is, making sure that they're, communicating closely and planning things in advance. So I think these discussions should begin early. In my own experience, sort of the best outcomes are when, obviously if these discussions are had before conception and hopefully, before that 6-month period, which talked about sort of controlling disease activity for at least 6 months leads to the best outcomes. Discussions would be best regarding preconception counseling. So not just sort of during the pregnancy, but having that relationship with the OB provider and that your rheumatologist is communicating well in advance. So if you are higher risk, you're aware of, the specific magnitude of the risk, how you can maybe in the, months going forward, reduce that risk, so whether it's controlling the lupus better or modifying your medications to a regimen that's fully compatible with pregnancy. I think sometimes also, having providers that are within the same health system, if possible, it's not always possible, is helpful, just because their notes can be more readily shared between the providers, or they can communicate easier, particularly in higher risk patients. Being able to communicate in a timely way, I think those make it easier, but that's not always possible. And so just making sure both providers are responsive to communication with you and with each other, I think is important. So I think those are the most important things. So yeah, I think with good communication, everybody being on the same page is the most important thing. You don't want to be in a scenario where your providers are sort of at odds with the plan. So I think just having them discuss things from early on avoids any scenarios where there's sort of a difference of opinion that may sort of adversely impact your care.
Can I get pregnant if I have lupus? I think they're asking about, does it affect fertility?
In most scenarios, lupus does not affect fertility. I presented a couple studies that suggest in a small subset of patients, there have been just a couple studies that have shown that lupus-specific factors may impact fertility, and that's an area of ongoing study. But the general consensus among the rheumatology community is that lupus, in and of itself, in most cases, does not. That being said, lupus doesn't, occur in a vacuum. You're also on medications for your lupus, and as we talked about, a number of, or some of the medications, particularly in patients who have more severe disease, can directly affect fertility. There are other factors, just trying to get your disease under better control. Women with lupus conceive typically at a few years later than women who don't have lupus. So independent of you having lupus, just that factor may decrease your ability to conceive. And so it's kind of a complex number of factors, but for most women with lupus, it's probably not the lupus itself that's affecting fertility.
What if anti-malarian hormone is low? What options are recommended to conceive?
So that's, again, it's hard to know exactly how to answer that question, just because that's based on one study that sort of looked at that. And that was fortunately in only about 15% of the patients with premenopausal women with lupus had those low levels. So again, is this a widespread phenomenon of lupus? It doesn't appear to be the case, and there's more study that needs to be done. But if it is low, I think there are these assisted reproductive techniques, which we discussed in the talk, that could be considered. And then if that is the case, there are these other factors we talked about, such as medications. So potentially transitioning you to a medication that may not directly affect fertility. So optimizing the things that are reversible. So if there are factors that you can modify to improve fertility, those should definitely be done, especially in that scenario, I would say. So I think working to improve your disease activity, because in general, if lupus in some women may affect fertility, as long as, like with anything, with improved disease outcomes and disease activity being as low as possible, that should improve success rates. There are these assisted reproductive techniques, which should be pursued with close coordination between your rheumatologist, a maternal fetal specialist, and a neonate, and a reproductive endocrinologist. And again, if you are already on a medication that has been shown directly to affect fertility, to transition to something that won't. So I think a combination of those things would lead to the best outcomes.
Okay. I have a cousin willing to carry a baby for me and my husband. I am on methotrexate. Will my eggs be okay?
We typically recommend a minimum of 3 months of transitioning off of methotrexate before trying to conceive, or these different sort of routes of conception. So methotrexate's been associated with adverse fetal outcomes, including malformations, et cetera. So if you yourself are on methotrexate, a minimum of 3 months of transitioning to something that is safer. So if your disease activity is lower, potentially you could transition off of it, observe, see how your lupus does on just a background regimen of, for example, hydroxychloroquine. Or but if you still have disease activity, typically in that setting, patients who are on something like methotrexate the analogous medication that would be compatible with trying to conceive would be azathioprine. So it sort of depends on your disease activity, but with regards to the methotrexate itself, a 3-month window is typically considered the minimum.
Okay. I have read women with lupus may experience menopause early. Is there a concern with waiting too long to have children because of this? Are there any tests for this to help me plan?
I mean, I think that the tests are the same as whether you have lupus or not to help sort of determine the menopause. But I agree with the person who asked the question that there is some data that in general, menopause can occur earlier in women with lupus. Not every woman with lupus will experience that, but so that's something to thinking about in advance in terms of family planning, in terms of you know, the timing of when you would conceive. The other key factors independent of that, though, are always whenever if you are considering conceiving earlier, in a recognition of that, always making sure it's in an environment where your lupus is as well controlled as possible, because again, that's consistently sort of a theme in these studies when they've looked at women with lupus, that you know, making sure your lupus is as well controlled going into the pregnancy, whatever age, will lead to the best outcomes. So I think, yes, you know, there is concern regarding some of these complications, but again, with advanced planning and working closely with your providers, I think that should not be a cause for like a loss of hope or anything in terms of how you can proceed.
Okay. Is it possible for my lupus symptoms to subside while pregnant?
Yeah, I mean, the patients with lupus have variable outcomes during pregnancy in terms of their disease activity. There are some women who their disease becomes more quiet during pregnancy. Some it sort of stays the same, and some it's more active. It's not sort of the same in everybody. You know, we did quote those sort of variable flare rates, but even in those cases, there's a proportion of patients who don't flare during lupus, and I have seen in pregnancies where sometimes the disease activity goes down. Not necessarily a rule that it does go down. Like, it's not sort of, I would say, like the most common scenario, but it can happen just like in other autoimmune diseases where that can sometimes occur. So yeah, I think, again, the likelihood of just preventing a flare, or at least staying where your disease activity was, is again best if for going into the pregnancy, things have been stable for at least 6 months.
Okay. I am currently taking 5 milligrams of prednisone, 3 milligrams of I'm sorry, I haven't seen this medication.
Is it tacrolimus?
Yes.
Okay.
And hydroxychloroquine and baby aspirin. Are these all safe while trying to get pregnant?
All of those, I would say, are reasonably, so they're all within sort of the recommendations from the most recent guidelines as well. Prednisone is conditionally, you know, recommended at lower doses if needed to control disease activity. So it really depends on your disease activity. If you need to be, the one I would just point out is the prednisone. So that's my sort of the caveat specifically. Like, as lupus providers, we always want to make sure the disease activity is optimally controlled. If there's any way that your provider is able to manage your lupus with those other medications and not require you to be on the 5 milligrams of prednisone, you know, that's always the sort of the dream scenario, to not be on prednisone. But if for whatever reason that last threshold of the 5 milligrams, it's been difficult and they're not able to sort of modify the other medications to get you off of prednisone, probably the sort of the magnitude of risks going into conception and during pregnancy with steroids are really dose dependent. So if you're on 5 milligrams, 4 milligrams, lower doses, while not non-existent, the risks are sufficiently low. So I can't sort of give you a yes or no answer, but with regard to the prednisone itself, but your risk is low enough that probably, you know, if there's no other way to adjust it, that, you know, just with close monitoring, they can sort of mitigate those risks during pregnancy. But yeah, ideally, the prednisone would be something, if whenever possible, coming off of it going into pregnancy. But you can have a successful pregnancy with it. There just are some risks with prednisone, but mild at this dose.
Thank you. I am 36 years old. and in complete remission of symptoms. My life is really good and I have a great job. I'd like to have a child next year, but I'm very scared of the risks to me and my baby. What would be your recommendations for her?
I mean, I think the studies that I presented sort of show that the majority of women with lupus can have successful pregnancies. There are specific risk factors, antiphospholipid antibodies, if you're sort of have hypertension or on an antihypertensive, or kidney involvement of lupus, sort of certain specific risk factors that increase the risk of pregnancy adverse outcomes. But even then, in the majority of time, for example, in that PROMISE study that we talked about, most women did not experience an adverse pregnancy outcome. So I think it really comes down to, I understand having anxiety going to this because it's such an important life event. And you mentioned age 36, so there may be issues with fertility that are developing. And so, but, looking at your specific, you as an individual patient, your provider should talk with you about, yes, you have lupus, but what are your specific risks with regard to these things that have been studied in the papers I've mentioned? And they can kind of give you a sense of if you're sort of in the lower risk category or higher risk, and in whichever scenario, they can work with you and your obstetrician about managing that risk. And like I said, in most cases, with a few select scenarios when there's like really, really high disease activity, a successful outcome can still occur. So I wouldn't sort of lose hope. I would just work closely with your provider and they can share with you how to proceed.
This one's kind of similar, but a little bit different. I know pregnancy risk is increased with lupus nephritis. How can I make the right decision for me? What should I be considering?
I mean, I think the risk in the studies is actually is more so, it's both in if you've had a history of lupus kidney involvement or active. So it's unclear from this question if you have had a history of it or it's still active right now. But in either scenario, you'd be considered a little bit higher risk. The same sort of principles apply, though. The 6-month window of controlling your disease activity. If you have nephritis, you may be on different medications than a lupus patient who doesn't have nephritis. So that may change, but the list of what are the safe medications going into pregnancy would you'd still want to follow. And so your rheumatologist will want to make sure that your lupus generally and in the kidneys is controlled, and that you're following sort of the safe medication regimen. But again, like I've mentioned, a successful pregnancy outcome certainly can occur. So in that scenario for you, you'd want to loop in your nephrologist. Your kidney specialist should be sort of in those early discussions. And I found that sort of including them with me as the rheumatologist and my patients who have lupus kidney involvement and the obstetrician, and sort of coordinating care before pregnancy, really make sure everybody's on the same page and you're on a regimen that everybody agrees on and that you're comfortable with. And so I think I would encourage you to work with all of those providers together.
Great. That's the questions that we have right now. I want to throw it back out to the audience. If you have any last minute questions, we'll give you a couple more seconds before wrapping up. Doesn't look like we have any further questions.
Okay.
But thank you, Dr. Chaichian. That was very interesting and informative. To the patients in our audience, please don't forget to fill out. Oh, we do have one last question. Are we able to get a list of the safe medications? I noticed that you had the list in the slide deck. Can we get one that we can email the patients, I guess?
I mean, that list comes from the 2020 reproductive health guidelines, which I was highlighting, and that is publicly available, those guidelines. So you can, they're the 2020 American College of Rheumatology guideline for the management of reproductive health in rheumatic and musculoskeletal diseases. So I can share maybe with, I mean, if LFNs see that the link, but it's publicly available as well. So patients should feel free to be able to review those. And the table that I sort of presented was adapted from that. So
we can send that link out to the registrant participants after the fact. We got another couple of questions in. What is the latest on whether lupus is genetic versus environmental? That's more of a general question rather than related to pregnancy, but.
That's a really important question. I mean, that's something that's sort of not yet settled, and it's not really unique to lupus. A lot of autoimmune diseases, the exact contribution of genetics versus environmental is still being debated and studied. As with most things with lupus, the risk sort of susceptibility is very complex. We think in patients with lupus, it's a combination of genetics and environmental, so it's not just one. The genetic component is complex in that it's extremely rare to be like due to one gene. And in the vast majority of patients, it's numerous genes, each contributing a slight risk susceptibility. That being said, you know, even in like twin studies, there's not always like concordance in terms of lupus. So genes don't explain the entire risk. In terms of environmental factors, you know, there's only a few that are sort of certain or clear factors that can increase the risk, like exposure to, you know, UV light, silica dust, which is in some environmental exposures in certain occupations, but a lot of other things that you may think would be exposures have sort of either been studied and found to be not risk factors or inconclusive. So there's a thought potentially mechanistically that certain viruses may sort of trick the immune system or have components to the virus that look like proteins the body makes and may induce the immune system to become revved up. And so it may play a role in some patients with lupus. But in any event, any of these environmental things are likely only in the setting of already having a genetic risk. So you kind of have to have both to develop lupus. So yeah, it's a complex issue, but we think it's both genes and in the environment, and some combination leads to your risk.
Okay, this one, a follow-up to that. My younger sister has lupus. I have lupus. My partner's mother has lupus. Given this, what are the odds my child will have lupus?
I can't provide a specific risk assessment based on that. I mean, I think, like I said, it certainly seems there's a very strong family history of lupus in your family. And so, you know, you certainly, I think the risk is greater in any member of the family because of that to develop lupus, but a specific risk assessment is difficult just because there are some factors related to lupus risk we don't yet understand fully. And like I mentioned, the genetic inheritance patterns are not completely straightforward. So I would say the risk is greater, but it's hard to sort of give a specific risk assessment beyond that.
Okay. What tests should women with SLE get regularly done during pregnancy to monitor disease activity, and how often?
They should typically, I mean, there are certainly certain obstetric tests, the standard, you know, tests that would be done by our obstetrician, looking for, you know, gestational diabetes, et cetera. Some of the risks, like in preeclampsia we talked about, so some of the monitoring may differ. And so that's at the discretion of your obstetrician, how frequently to monitor for those. The actual lupus-specific monitoring that I think you're referring to, those are often the same tests that are done outside of pregnancy. So looking at the blood counts to see if, you know, your counts are low, which often can sometimes be a sign of lupus activity, the complement proteins, the double-stranded DNA levels, checking the urine for protein, which is doubly important after 20 weeks because you think about preeclampsia and lupus kidney involvement can kind of look similarly. So, you know, in somebody whose things are very stable, like, you know, each trimester checking some of those, you know, it may be sufficient, but in many patients, you know, if there are other risk factors they go into pregnancy with, like a history of lupus nephritis, or if they're going into pregnancy and not at like the lowest risk or disease activity, like they have some disease activity, these things are often checked more often. So it's sort of it's individual And in 2020 guidelines, we talked about at a minimum, they mentioned, physical exam, a check-in with your provider, and monitoring at a minimum every trimester. But again, that's the minimum, and many patients may need a little bit more monitoring. So it should just be individualized to exactly what your lupus is looking like.
Thank you. That looks like all the questions that we have. So thank you again. Thank you for your time. The answers were wonderful, so informative.
Thanks so much. Thanks everybody for inviting me. It was great to be able to talk with you about this important topic.
To the participants in our audience, don't forget to complete the survey. This is the end of session 1. We hope you will join us again at 2 p.m. for our patient panel. Remember, you can join us by clicking on the same link you used this morning. Thank you.